Advanced Colorectal Surgery and Anorectal Pathology Clinical Guide.
Colorectal Surgery Board Review.
Question 160. A 38-year-old male presents with multiple, complex, recurrent perianal openings that continuously discharge purulent, blood-stained fluid. On physical examination, extensive induration is palpated extending superior to the level of the puborectalis muscle. Which specialized diagnostic tool is preferred here to map this complex anatomy? Is it A. Ultrasound, B. CT, C. MRI, D. Fluoroscopy, or E. Core biopsy?
Correct answer is C. MRI. So the crucial point is that for complex, recurrent, or multiple fistulas and ano presenting with extensive induration tracking way above that sphincter apparatus, a dedicated pelvic MRI is absolutely your imaging modality of choice. It gives us incredible, superior soft tissue resolution right within the levator ani and ischiorectal spaces to accurately map that primary track. Remember the criteria for a complex fistula? We're talking multiple external skin openings, a recurrent tract, extension tracking superior to the puborectalis muscle, or a transsphincteric tract crossing more than 30% of the external anal sphincter. Getting this accurate preoperative MRI mapping is literally a game changer. It minimizes the risk of accidentally dividing the external sphincter muscle, which drastically reduces the probability of postoperative fecal incontinence for the patient.
Diagnostic distinctions: right versus left lower quadrant abdominal masses. When looking at an appendiceal mass, we typically see it in young adults in the right lower quadrant, presenting with classic migratory acute appendicitis pain and a tender, firm phlegmon. Management involves a conservative Ochsner-Sharon trial followed by interval appendectomy. In contrast, cecal carcinoma appears in older adults, also in the right quadrant, but features chronic anorexia, a stony, hard, non-mobile mass, and severe microcytic iron deficiency anemia, demanding an elective oncological right hemicolectomy. Shifting to the left quadrant, a sigmoid diverticular abscess usually strikes the elderly, presenting with a history of diverticulosis, cramping, and a tender, warm pelvic mass. The primary management strategy here is percutaneous CT-guided drainage or a Hartmann's procedure if perforated.
Question 161. An elderly male diabetic patient with poor perineal hygiene presents with severe anal pain and fever for 6 days. Examination reveals a painful, tender swelling just at the anal verge. The correct answer is C, a perineal abscess. This originates from an acute cryptoglandular infection of the anal glands lining the dentate line. What happens is, obstruction leads to bacterial stasis and suppuration tracking right into the perineal spaces. Now, the diabetic urgency here is absolutely critical. In diabetic patients, these infections can spread like wildfire along fascial planes, strongly predisposing them to necrotizing soft tissue infections or Fournier's gangrene. Keep in mind, unlike an anal fissure where the pain is strictly tied to defecation, an abscess produces a constant, severe throbbing pain.
Question 162. Which of the following anorectal abscesses spreads to other sites as well? Correct answer A, ischiorectal abscess. An ischiorectal abscess forms when an infection breaches the external anal sphincter below the level of the pubococcygeus muscle to fill up that fat, dense ischiorectal fossa. Because the deep postanal space connects the right and left ischiorectal fossa posteriorly, the infection readily spreads over to the contralateral side. This forms what we call a pathognomonic horseshoe abscess. These tend to contain massive volumes of pus and present with diffuse, indurated swelling straight across the buttocks.
Question 163. A middle-aged patient presents with pain during defecation. A perianal fluctuant and extremely tender swelling is palpable. What is the treatment? Correct answer B, incision and drainage. The definitive treatment here is immediate surgical incision and drainage. Delaying this to just give antibiotics is a very serious clinical error. The fundamental surgical axiom applies here. Ubi pus, ibi evacua. Where there's pus, evacuate it. The cruciate technique is often used, utilizing a wide, cross-shaped skin incision directly over the fluctuant core, and actually excising those corners to prevent any premature closure of the wound.
Question 164. 5 days post-laparotomy for a perforated duodenal ulcer, your patient has a subphrenic abscess. Do you manage this with A, intravenous fluids, B, antibiotics, C, image-guided percutaneous drainage, or D, open exploration with a drain?
Correct answer is C, image-guided percutaneous drainage. A localized, unilocular postoperative organ space collection is optimally managed this way, combined with targeted IV antibiotics. We do this to entirely avoid the high morbidity of a reoperative laparotomy. And this brilliantly illustrates the protocol for catheter maintenance. You see, The indwelling catheter remains in place until the patient's fever completely resolves, their leukocytosis normalizes, and daily fluid output drops below that crucial 10 to 20 milliliters mark.
Question 165. A 47-year-old patient is planned for elective colorectal surgery for colonic carcinoma. Which holds true regarding preoperative preparation? Correct answer, B. Mechanical clearing and a single-dose antibiotic. The standard protocol involves mechanical clearing and a preoperative single dose of antibiotics to cover both gram-positive and gram-negative bacteria. Prophylactic antibiotics targeting native bowel flora absolutely must be administered within 1 hour before making that surgical incision. While it's mandatory for rectal operations to facilitate low anastomosis, routine mechanical bowel prep is frequently minimized these days in uncomplicated right-sided colonic resections under modern ERAS pathways. Furthermore, don't forget that colorectal cancer patients represent a notoriously high-risk group for venous thromboembolism. This mandates sequential compression stockings and low molecular weight heparin.
Question 166. In the case of fecal occult blood testing, which of the following does not interfere with result interpretation? Correct answer. E. Potato. Traditional guaiac-based tests rely on a chemical pseudoperoxidase reaction, and consuming potatoes simply doesn't interfere with it. However, false positive promoters include things like red meat, turnips, broccoli, or iron preparations. On the flip side, false negative promoters include high-dose vitamin C, which directly interferes with the oxidation reaction itself. To get around all this, modern screening preferentially utilizes the fecal immunochemical test, or FIT, explicitly to eliminate these pesky dietary interferences.
Question 167. For which of the following features is the Alvarado score maximum? Correct answer? E. Tenderness in the right iliac fossa. Within the 10-point Mantrell's matrix used to diagnose acute appendicitis, almost all parameters are assigned just 1 point. The exceptions are 2 core features weighted at a maximum of 2 points: localized tenderness in the right iliac fossa and leukocytosis greater than 10,000 per cubic millimeter. A total score of 7 to 10 is highly predictive of acute appendicitis and fully validates immediate surgical intervention.
Question 168. A 45-year-old male patient presents with features of bladder outlet obstruction. He had undergone resection of a rectal carcinoma 1 year back. The carcinoembryonic antigen, or CEA levels, are raised. Which investigation is best to detect recurrence? A. CT scan, B. Ultrasound, C. Colonoscopy, D. MRI, or E. PET scan?
Correct answer is D. MRI. Now, what's really interesting about this slide is the concept of the extrarectal trap. You see, most local recurrences develop extraluminally, hiding right within the surrounding connective tissue planes of the mesorectum. Because these local recurrences track within the pelvic fat pads or pelvic sidewalls, a follow-up colonoscopy can actually return completely normal mucosal findings, even in the presence of an extensive invading tumor recurrence. A high-resolution pelvic MRI provides superior soft tissue contrast, letting us differentiate post-radiation fibrosis from an active tumor recurrence and accurately assess local invasion.
Question 169. An old patient presents to the OPD on follow-up 3 months after carcinoma anterior resection, 9 centimeters from the anal verge. What should be done? Correct answer? D. Tumor markers. Tracking serial CEA levels every 3 to 6 months is your essential baseline screening step. A progressive, linear rise in CEA levels is highly sensitive for catching early recurrence. Routine follow-up colonoscopy is standardly deferred until 1 year post-resection to evaluate for metacrinous polyps or local anastomotic recurrence.
Question 170. Which is the investigation of choice for preoperative staging of rectal carcinoma? Correct answer, C. MRI. For preoperative staging of rectal carcinoma, a high-resolution pelvic MRI serves as the absolute gold standard. The primary purpose here is to measure the exact distance between the outermost edge of the tumor and the mesorectal fascia to define the T and N status. If this distance is 1 millimeter or less, the circumferential resection margin, or CRM, is considered threatened. This indicates the definitive need for preoperative neoadjuvant chemoradiotherapy to downstage the tumor before taking the patient to surgery.
Question 171. A 3-year-old child presents with a recurrent mucosal protrusion through the anus during defecation. On examination, a full-thickness concentric rectal prolapse is identified. What is the preferred initial treatment for this condition? A. Digital repositioning then sclerotherapy. B. Delorme procedure. C. Thiersch wiring, D. Rectopexy, or E. Anterior resection?
Correct answer. A. Digital repositioning, then sclerotherapy. Pediatric rectal prolapse is frequently just a self-limiting mucosal condition. The first-line approach is always conservative, digital repositioning based on proper parental education. If that fails after a strict 6-week trial, then you attempt local injection sclerotherapy utilizing 5% phenol and almond oil injected straight into the submucosal space. Infants have an anatomical predilection for this because their sacral curve is not fully developed yet. And here's a huge pearl. Always screen these recurrent idiopathic cases for cystic fibrosis using a sweat chloride test if there isn't an obvious diarrheal trigger.
Question 172. A 49-year-old patient returns to the clinic 3 months following an open excisional hemorrhoidectomy, complaining of progressive, severe difficulty passing stools. He has thin, pipe stem stools and a tight, fibrous ring is palpated within the anal canal, but he reports no pain. What is the diagnosis? A. Recurrent hemorrhoids, B. Anal fissure, C. Rectal prolapse, D. Postoperative anal stenosis, or E. Rectal carcinoma?
Correct answer is D. Postoperative anal stenosis. This is a classic iatrogenic complication. It occurs when the primary surgery trims excessive amounts of anoderm and mucosa without leaving adequate intervening intact bridges of skin, which ultimately causes circumferential scar contracture. The golden rule of surgical prevention here is that the surgeon executing a 3-column hemorrhoidectomy absolutely must leave broad, distinct mucocutaneous skin bridges between the excised hemorrhoidal columns. If you're dealing with mild strictures, they're managed with sequential mechanical anal dilation, while severe cases are going to require surgical correction via a formal anoplasty.
Question 173. A 91-year-old male is brought to the clinic presenting with a prominent, concentric, full-thickness mucosal protrusion and an apical ulcer across its apex. What is the most likely diagnosis? A. Full-thickness rectal prolapse, B. Prolapsed internal hemorrhoids, C. Rectal polyp, D. Anal malignancy, or E. Perianal hematoma?
Correct answer, A. Full-thickness rectal prolapse. The key diagnostic difference is that a full-thickness prolapse displays pathognomonic concentric mucosal folds. On the other hand, prolapsed internal hemorrhoids display broken, radially oriented sulci separating the vascular columns. Friction and vascular congestion across the prolapsed mass lead to that localized mucosal ulceration and bleeding, which, if left unmanaged, can actually progress to gangrenous ischemic necrosis. When it comes to surgical repair options for older adults with significant comorbidities, we preferentially utilize perineal approaches under regional anesthesia rather than transabdominal sacral rectopexies.